introduce our third keynote speaker, David G. Bostwick from Rampart Health here in the United States. Dr. Bostwick is the founder and CEO of Rampart Health. He is an internationally renowned urologic pathologist with more than 35 years of experience and interest in prostate cancer and urologic diseases. He was formerly the professor of pathology and urology at the Mayo Clinic from 1991 to 1999. Dr. Bostwick founded the Bostwick Laboratories in 1999, a private multinational medical diagnostic laboratory specializing in anatomic pathology. He served in leadership roles including Chief Medical Officer, President, CEO, growing the company from 1 employee to over 1,200 employees, with an annual revenue of $179 million before the company was sold to a private equity firm in 2011. As CEO, he developed a diagnostic pipeline through licensing and internal R&D, including the first commercially available molecular diagnostic test for prostate cancer, PCA3, which is designed and administered in an FDA clinical trial of intratumoral immunotherapy combined with cryoablation, and served as co-investigator of the successful 4,000-patient GlaxoSmithKline REDUCE trial for prevention of prostate cancer. Dr. Bostwick is currently the Chief Executive Officer of Rampart Health. He has authored and edited 18 books, more than 30 book chapters, and more than 500 professional peer-reviewed papers. His book, Urologic Society Pathology, is a best-selling uropathology medical textbook. Other bestsellers are his books, American Cancer Society's Complete Guide to Prostate Cancer and Essentials of Pathology, 3rd edition. He has presented more than 2,000 lectures around the world and is the founder, past and present, of the International Society of Urologic Pathology. He holds a bachelor's in biological sciences and an MD from the University of Maryland and an MBA from Loyola College of Maryland. He has served on the medical school faculties of University of Chicago, University of Maryland, and the Mayo Clinic. He is aware of the importance and frequent communication among project members and of constructing a realistic research plan, timeline, and budget.
I don't actually know who that was he was talking about.
Forward, backward, and laser pointer.
Very good, thank you. It's a great pleasure for me to be here. I'd like to do two things. First, I'd like to share a story of how I got to where we are with our clinical trial. And then secondly, for the first time, I'd like to present the final data that we've just derived from that trial. It's a small trial, but I think it's exciting. Thank you. And thank you for the introduction. Can we go to, okay, I've got some disclosures. The most important one here is that I am actually the CEO and founder of Rampart Health. This landmark book, Pulitzer Prize-winning book about 15 years ago, highlighted the excitement in oncology with the first serious cure. Acute lymphocytic leukemia in childhood was a death sentence in the 1940s, 50s, and 60s. And this book highlights how in 10 years we went from using one drug to using ultimately 3 and then 4. And the 4 drugs actually came in the 1970s. They've been modified slightly, but not a lot, remarkably, in 50 years, because we now have a cure rate of well over 90% in all patients. So this is absolutely positively a cure in many of these patients. And some of them from the 1960s are still alive today. So in thinking this through, we've heard about combination vaccine therapy, which I think is very powerful, from our previous colleague that spoke, and I agree with her. And I think the same applies in cancer treatment. The problem are side effects. And if you put in 3 or 4 cytotoxic drugs, as they do here, the adverse event rate soars, up to and including death. So you walk a thin line between doing too much and killing the patient, or doing too little and then letting the disease itself have the adverse effect. We came up with the idea of what we call MITI, multiplex immunotherapy, intratumoral immunotherapy. And following on some of the concepts we heard from Dr. Zaz earlier, that was elegant, by the way, in my opinion, we believe that the use of that ablation therapy to unleash the cancer antigens and to disrupt the cell membranes and create both necrosis and apoptosis, as we heard about, is central to making this work most effectively. So you start with an ablation, but then you add drugs to it. And in our early trial in about 20 years ago, we used dendritic cell therapy, and we got a response, a signal. We never published the results because it was a small trial, but it worked. It worked modestly. But the revolution came in 2014 with the FDA clearance of the first PD-1 inhibitor. And that, I think, has revolutionized and changed our world, leading, of course, to Nobel Prize. But more importantly, we now had some cures for the incurable metastatic melanoma, the first target that they went after. But by itself, the PD-1 inhibitor doesn't do as much as we would like. It's between 6 and 25% curable, short-term cure in melanoma, and lower in most other diseases. When you add other monoclonal antibodies to it for systemic therapy, then the side effect profile soars up to and including death. So if you add a CTLA-4 inhibitor like Yervoy together with your PD-1 systemically, you're going to kill some people. At least that's been shown in some trials. Not that many, but it happens quickly. It's thought to be a hypersensitivity reaction. Our belief has always been intratumoral injection is the way to go. We're going to hear this later on from Dr. Yu as well in this conference this afternoon. Intratumoral injections allows you to give more therapy locally to the tumor. So we came up with 4 mechanisms and intratumoral, and that's really the advance, we think, of what we've done here, and those are the results that I want to share with you today. So we expose the cancer antigens by doing the ablation, similar but not identical to Dr. Zaz. We use cryosurgery, and without going into the details, we're trying to keep the cancer antigens as intact as possible. And while hyperthermia, low-dose hyperthermia can do that, electrical energy, as per Dr. Zaz, is a fabulous way to do this. We just happen to have cryo readily available. So that's what we used, and we've used that. But we don't do it the way everyone else does cryo, where you do double freezes, you create a liquefied tumor in the middle, and it's all, you try to destroy all of it and keep the margins of the cancer involved, so you get everything. We don't do that. We freeze something the size of a marble inside the cancer. We do that for 2 reasons. Number one, we're only priming the pump of releasing the cell membranes, the antigens, hopefully intact within. So if you do enough cryo, you will liquefy the tumor, and of course that's necrosis. It destroys everything, and it destroys the 3-dimensional structure of the unique cancer neoantigens. And your cancer is going to have different antigens than I'm going to have. So we are agnostic on the number of antigens or the different types of antigens. You could do trials like a lot of people are doing where they choose the antigens ahead of time. I was involved in the Provenge trial for prostate cancer many years ago, and they chose 1 antigen. And it kind of sort of worked a little bit, 4 months of survival, side effect profile, not so good, very expensive, still available and used in the United States. I'm not a strong proponent of it. I'm not against it, but it's not the cure that we're looking for, that we're reaching for. So we're agnostic on the antigens, and we want them all there. And we also want them because in the metastasis, it may be actually different repertoire of neoantigens than you have in the primary. So when we do our treatment, our ablation treatment, we do at 2 sites, preferably the primary. If we don't have the primary available, then we do it in 2 other sites. We do the ablation, and then we inject 3 drugs. So we are unmasking the cancer antigens with a PD-1 inhibitor. Then we are blocking the immune feedback loop we all know about, in which after about a week to 2, the helper suppressor T cells stop the immune system. We don't want it to stop. We want it to keep going for about a month or so, which is the little more than the half-life of the monoclonal antibodies we use. So we use an anti-CTLA-4, and a PD-1 inhibitor. We also use low-dose cyclophosphamide. Cyclophosphamide is a cytotoxic agent, an alkylating agent, but at low doses, it actually has very weak, if any, cytotoxic effect. But it actually has great immune-stimulating effects as well. Just as an aside, the supplier of GM-CSF in the United States, there's only one, is based here in Waltham, Massachusetts. But I don't have anything to do with them. It's just an interesting aside. And then the final thing is you want to mobilize the killer T cells because they're the soldiers that do the killing of the cancer cells. The dendritic cells, of course, are the antigen-presenting cells are the ones that start the process. But the killer T cells do the actual work of sacrificing themselves in destroying the cancer cells. You want as many of those as you can get. You give a shot of GM-CSF systemically, and then it mobilizes. The problem with GM-CSF is that its half-life is only a few hours. So you have to give it on a daily basis, and then you get peaks and flow and ebbs in the thing. So 4 mechanisms, complementary mechanisms, different mechanisms to address the issue of anti-tumor treatment, and we call it multiplex. I don't like the name necessarily, but that's what it is. And intratumoral is the central part of this. This has been talked about. The intratumoral injection of immunotherapy has been talked about for 10 years. There are no published prospective studies on that trial, on that thing. There are some abstracts, but there are no published ones. What I'm presenting today is the first in human. I'm excluding colitic viruses. There are studies on that. But excluding that and maybe a handful of other things that I've missed, there's nothing that's looked at it using the 2 main monoclonal antibodies that we're using today, the PD-1 inhibitors or PD-L1 inhibitor and the CTLA-4. So that's just as a background of what we're doing. So if you compare this to systemic immunotherapy, we're hitting 4 targets, not 1 or 2. We're looking at all the cancer antigens. We don't know how many. Is it 100? Is it 1,000? We don't know. The drug doses we use are much lower, which is interesting, although we can use the same dose. When you put it in intratumorally, and then you follow it as we do with a hydrogel collagen, it actually locks the stuff in there, so it continues to do its thing locally inside the cancer. The reason we use a marble size is to allow the blood vessels and lymphatics that feed the cancer to allow the cells to get in and get out, because you want that signaling, you want that to occur. If you kill the whole thing, then you're going to lock at least the center of it out of the immune system. And we want the whole thing to work. So that's why we make it small and readily available. Again, serious adverse events. I've used the Proventure Cell as the comparative here, and you can see it's superior to that. And my favorite word in the English language, Abscopal, is operative here. It's been predictive in a minimum of 31%. I'll show higher numbers for some of the other things we've done, and a disease control rate of 77% prospectively. We presented those data in 2023. That was the preliminary findings, and today I have for the first time the final results of this trial, so we could talk about survival. The unmet need is pretty straightforward. We're all familiar with the fact that if you look at distant 5-year survivals, they're dismal, and they really haven't changed much. We talk about how we're winning the war on cancer, but if you have metastatic cancer, whether it evolves over time or you present with it, you don't have a great outcome in some cancers. And we see that, and we all live that through our friends, our colleagues, and people that we know. So we want to do something about that. And everything I'm going to present to you is in patients who have metastatic cancer, who have failed everything. They've all had surgery, at least most of them have. They've had radiation therapy, if that's appropriate, and they've all had chemotherapy. So every one of the patients from now on have had everything, and they're at the end. This is called salvage therapy, and that's the word that I'm using, and it's really true here. So here's my favorite story in my career. This man arrived in 2015. We were not going to do this out of animals. We were in animals at that point. We were not going to do this until about 2019. But he had failed everything. He had had cancer for a little over 20 years, and He had surgery for his prostate cancer. His prostate was removed, but there's still a space there called the prostatic fossa where the tumor came back. He had radiation therapy. He had hormonal therapy. And ultimately, he had the early types of chemotherapy in prostate cancer that offer some benefits lasting weeks or months, but not years. There's no years here at all. Surgery, of course, is the best for what he had because he had a high-grade cancer, at least an 8, which is a high on a 1 to 10 scale. So he comes back 16 years later. He's now 72 years old, and he begs us. I don't even know how he found us, but he begged us that he wanted to do our treatment. And under compassionate use exception, because we're using FDA-cleared drugs and an FDA-cleared device that is cryosurgery, which is available. We put these together and we gave it to him. It takes an hour. It's done while you're awake and it's painless. You have to give yourself GM-CSF shots for a month. They're simple abdominal shots, it's like taking insulin shots. It's pretty straightforward. And that's it. His cancer went away. Well, maybe it didn't. It turns out that the mass in the prostate that was there, had grown back, was still there. It had shrunken by about 50%, but it was still there. And but the lymph nodes that he had, his metastases that were in multiple places, was all gone. So the lymph nodes are gone, but the prostate tumor is there. But what's interesting is his PSA dropped to literally undetectable. We used a high sensitivity assay at that time. And it was undetectable at last follow-up last September. So it's now gone essentially a little over 9 years. I don't have follow-up to today, but I presume it's pretty much the same as before. So he's gone 9 years with no cancer. But what happened to the tumor in his prostate that's still there? Is it cancer? We didn't know. Should we biopsy it? We decided not to for 3 months because, as we heard earlier, you treat the patient and not the lab test. And as a laboratorian pathologist, I'm biased, but I still believe the patient should be treated. So in the end, we waited, and after a year, we just couldn't help ourselves because the mass was still there. We biopsied it. Before I get to that, his lymph nodes are completely gone, as shown in the imaging here. And this is what the prostate biopsy looked like. It's lymphocytes, fibrosis, and chronic inflammation. And that's it, the whole thing. I mean, well, the biopsy, I should say. And he's had no regrowth since that time. The mass had blocked his prostate and all the plumbing that goes with it without going into details. We were able to undo that after the treatment because the tumor shrank enough to allow the plumbing so we could reverse his diversion. We put in nephrostomy tubes before, and he didn't need those anymore. So we were blown away by this. So I had 3 questions. Is it durable? Well, I now could tell you it's 9 years. Is it reproducible? And I wouldn't be here if it weren't. And the third and the most interesting question is it generalizable? Will it work in all cancers? We heard from a question earlier from one of the colleagues that you're going to need different treatments for different forms of breast cancer and other things. And I've gone around the world saying exactly that as a pathologist. We have well over 100 types of cancer. You're going to need well over 100 different types of treatment. Is this generalizable? Could it be? We did a study ultimately of 17 patients. And we published this in the AACR as an abstract. This is a retrospective study. It's limited in size, but it's in metastatic prostate cancer. Again, patients who have no other possibilities. We had a complete response in 35%, and we have a survival with a mean of 26 months of 86%, which is great. That's all-cause survival, not just prostate cancer. The adverse event rate, the hypothyroidism, we think that was because that was pre-existing. We did not test for it before we did the treatments. We got smart, don't get me started. We got smart on that and we started testing for that, and our hypothyroid rate today is 0 because it's pre-existing. So it's not caused by the treatment. Skin rash is higher. GM-CSF, if you take it for more than a month, will likely cause a skin rash, likely meaning 51, 52% or higher. Easily treated with off-the-shelf drugs that you can get anywhere. And then you can see there are a couple of other interesting things. The prostatitis occurred, and then we had a couple of endocrinopathies. We didn't have any of the serious endocrinopathies, and of course, no deaths. And remarkably, nobody was hospitalized. Even the perinephric abscess was able to be treated without hospitalization. This is a limited study. It's observational. It's a small number of patients. The long-term follow-up, I can't tell you beyond the 9.6 years that we have. It's off-label use of drugs and devices, so I cannot recommend this to you today for use, and it's a two-provider experience. Limited, limited, and limited. But today I can present to you for the first time again the results of a prospective study. This is our preliminary data that we presented before, and at that time with 13 patients, again, a small study, limited, and it's in metastatic solid cancer. So we've got prostate in here. There was a breast cancer patient, 2 sarcomas, a bladder cancer patient, a whole menagerie of different cancer types. But again, to address the issue, is this a generalized treatment? We weren't looking for FDA registration here. We were looking for proof of concept in different things. And I think we got it. Disease control rate is 77%. But again, my favorite, the abscopal effect. It's actually probably higher than this because we had some dropouts early on. But 31% of these patients had cancer that responded at sites that we never treated, sometimes great distances, including liver and bone, the 2 visceral metastatic sites that are just so vexing to the oncologist and all of us. And the grade 2 adverse event rate, these were mainly due to the cryosurgery, and I'll leave it at that, but it was 16%. So it looks like it works. Going through a couple of patients, and I'll be very quick about this. 67-year-old with metastatic myxoid fibrosarcoma. He had amputation, ultimately had radiation therapy, and then he came to us in 2021 with metastases in the lung, of course, at the site of previous amputation. He had it in his axillary lymph nodes. So we injected 2 sites, and he had an injection site discomfort, as some patients do, and then some sinusitis, but no other problems. And after the first treatment, we had shrinkage of the axillary lymph nodes, which were treated directly, and the right proximal arm as well. These eventually shrank to the point that they were gone, which is nice. But this was the best part. There was shrinkage to the point that it was essentially gone. Still visible, but if you get below a certain level, like 1 centimeter for a lymph node, it's considered a complete response. So we had 68 and 71% shrinkage on an abscopal basis, which of course we're very happy about. And it was in both lungs, which is even more interesting. As a pathologist, I have to put some pictures in, so forgive me for that. But on the left is, it's a grade 3 fibrosarcoma. This is the grade 2 area chiefly. And on the right side, it's scar tissue. It's fibrosis. If anything, we're creating fibrosis. And that creates the problem of pseudo-progression. We have a mass there. The mass shrinks, but it's still there. What is it? And like the prostate patient at the beginning, it's a response to injury. It's a scar tissue, remarkably little inflammation in this particular patient. One other patient, and I'll be done with this, a 38-year-old woman with metastatic squamous cell carcinoma, given over to hospice care, came to us for treatment, and she had a lymph node metastasis disappear after the first treatment. The second treatment, I'll show you in a moment, and then finally, after the third treatment, it was gone. This is the only area in the biopsy that was taken after the second treatment, and it's a microscopic focus of residual cancer. The vaginal mucosa is at the top. You can see the squamous epithelium, and then it's predominantly scar tissue. Most of that they're lymphocytes, but you can see that there are a couple of residual cancer cells. They're obviously large. The nuclei are large and hyperchromatic, and there's actually a mitotic figure in one of them, an abnormal mitotic figure. But that's it. There was nothing else. There was a large resection that they did here, and this is the only focus that we could find throughout the fibrosis. The radiologist said that there was a huge tumor that was there, when in fact that's the only residual that we could find after the second treatment. Abscopal effect has been seen in 4 patients, one with myxoid fibrosarcoma that I showed you, a bladder cancer patient. A remarkable story there. He had lung involvement. We didn't treat the lung. We treated some lymph nodes, mainly in the inguinal area. And he had an abscopal effect in his liver and his lungs. I mean, it was phenomenal. And it happened after the first treatment. That was the best part for us. Cervical cancer I've shown you. And then the sacral chordoma lady had multiple nodules that regressed that were far away from where we did the treatment. So we think it's something that is predictable for the first time in metastatic cancer. And I'd like to see that number of 31% to rise, because this is a very powerful thing, as we heard from Dr. Zaz before. And this is the new data. Our median progression-free survival was 5.4 months. If you look at salvage therapies in general, and again, the comparator here isn't fair one way or another. It's lower than 5.4 months, and the median overall survival was almost 2 years. If you look at salvage therapy in these patients, particularly the breast cancer lady who did quite well, it's lower than that. We think these numbers can improve. This includes patients who only had one treatment and then just dropped off for whatever reason. Nobody dropped off because of treatment side effects. That's the best part. And this is the adverse event rate. I'm nearing the end. We had grade 1 to 2 adverse event rates, and you can read this for yourself, in 53%. And we had a transient pneumothorax. Again, it was a treatment effect with the cryosurgery needle, if you will. And I'll just leave it at that. We had no deaths. We had nothing near that. No hospitalizations were required. So even though the adverse event rate is high, it was all treated very easily. Most of these were grade 1, with a handful of grade 2, and then a small number of grade 3. So we conclude that this is a novel approach. We love intratumoral, and we love combinations of things. Intratumoral allows you to put things together you can't do systemically, and that's the power of it. We use a proprietary cryoablation technique, as I've mentioned. You can have better concentration of drugs with a lower adverse event rate, which I think is powerful, and it gives a favorable disease control rate, favorable, essentially all outcomes I think were favorable, and it consistently elicits the abscopal effect in humans for salvage therapy, and that's I think the part that gets me excited. We also think that it's a generalizable treatment, and that's even more interesting. We have treated, without giving you the data, we've treated 4 patients with metastatic pancreatic cancer. 2 of them have had resolution of their tumors. I mean, that was great, as you might imagine, but it's not publication quality other than case reports at this time. We're hoping to do that in the future. We're looking at hormone-positive, HER2-negative breast cancer, as well as bladder cancer in our next set of trials, which I'll probably have ready in 4 or 5 years, because these things take so long. But I wanted to share with you our enthusiasm at this approach, if you will, this I think a paradigm that's coming out from some of the pioneering work we've already heard from Dr. Zaz and others, and we'll hear more this afternoon. This intratumoral approach, I think, is a very powerful one, and again, it decreases the side effect profile very favorably. So I'm very grateful for you listening to me this morning, and I appreciate the opportunity to present to you. Thank you. Okay, thanks.
Does anyone have any questions? I'll bring the mic down to you real quick.
Very interesting. Chuck, question for you. When I noticed all of the patients, I didn't see from a salvage standpoint they had prior checkpoint inhibitor treatment. They looked all to not have prior checkpoint. What would you think the results would be if they had prior checkpoints?
In this trial, we had no one who had prior immunotherapy. That was not an exclusion criteria. It just ended up this way. But we've treated about 300 patients with this therapy, again, compassionate use exception. My colleague, Dr. Onik, has. And of those 300, there have been a handful that have had prior therapy. and they do very well. In fact, we look forward to that. As an aside, you reminded me, I didn't want to treat our first prostate cancer patient because we've heard about immunosenescence from a previous colleague this morning, and we're all aware of the fact that your immune system starts getting worse as you get older. And this guy's 72, he's had everything. He's had radiation therapy, he's had chemotherapy for some time, and he's not a young guy. And I'm thinking, this is our first patient. This is a really bad choice. We're not going to get a good response from him because of that. And yet it worked. It worked very well. That was in 2015. In 2018, this data was not available at that time. We published it in 2020. It was an abstract, so no one really noticed it. But it was interesting. In 2018, one of the colleagues from Memorial Sloan Kettering wrote an article on how prostate cancer, particularly metastatic prostate cancer, is immunodead, and the world had just watched a $120 million clinical trial crash and burn on prostate cancer. I won't go into those details, but it was interesting to read that editorial, even as we're sitting there on a patient who had now, he was 3-4 years out from treatment that worked. So immunodead is relative, and you would think that it wouldn't work in prostate cancer, or immunocold is a better word. I'm sorry for being casual, my words. But the key to this is that I think we can coax some pretty good responses, even from those things that we don't expect. So I don't quite understand what immunocold means in the face of combination immunotherapy. That's my thought, personal thought. Thank you. Okay. Thank you for your question.
Nice talk. We practice intratumoral therapy over 26 years.
Yes.
We understand the chemotherapy, kill tumor, may elevate the immune response for the T cells know who is cancer. Then you plus the PD-1, let the T cells more activity, more specifically. But when we talk about the control rate, it means we the intratumor injection induce the inflammation. So we are the evaluation the control rate, CR, PR, or stable. What time at the point is best?
I don't have an answer for that. What's the best time point?
Yeah, for evaluation the control rate.
Yeah.
For the CR or PR or stable, after you treatment.
Well, if you use control rate to the point that you stop the trial or the trial's over, it's going to go longer than if you do it after, say, 3 months.
Oh.
And your question is very apt because I asked that question as well.
Chemotherapy, 1 month. When you finish, then 1 month.
Right.
Since we are local injection induce the inflammation.
Yeah.
The point delay.
Yeah, this is a critical point for the people that don't understand the question. At what point do you call it a complete response? Is it a month after you finish therapy? If I had done that, I would have given you a complete response rate in our trial of probably 40%. But we pulled it further than that. We pulled it to the end of the trial. And if you do that, you'll notice that in our prospective, I didn't show you any complete responses. We talked about disease control rate, overall survival, and median progression-free survival. But if these patients live long enough and you don't repeat it, they'll succumb to it. That reminds me of another point. We've given our treatment up to 8 times in our patient with the sacral chordoma. The results I presented here were after 3 tries because that's what the trial called for. But we continued treating her with this. And it was interesting. The adverse event rate didn't change. It stayed where it was. She had some skin rashes and she kept having them, although she could treat them very effectively, and she stayed on the therapy. So it can be done, and I know, without going into other data, I know that you could do this up to 10 times, at least 10 times, and get more and more responses as you continue on. So the adverse event rate does not go up, and the efficacy does not appear to decline over time. So you continue to get sort of a bang for your buck even in the 5th and 6th treatment. So if we had done this instead of 3 times, which is what we limited it to, if we had done this 10 or 15 times, well, I think 15 would be excessive, but 10 times the way chemotherapy is normally done in some settings, we probably would have had a better response. I think we will, and I'll be able to tell the answer to that again when we finish these trials that we're hoping to start very soon. Thank you. Yeah.
Yeah, thank you very much. It was an excellent talk, and I have found a lot of similarities with our thinking. Okay, I have two very short questions. The first, have you applied any androgen blockade during the treatment?
We have not in this particular setting, in our trial, but I know that in part of the anecdotal treatment, not the 17 that we published on, but since that time, there have been patients who are on hormonal therapy and the doctors want to leave them on that. And it turns out, to the best of our knowledge, without giving you any formal data, it appears not to have a significant adverse effect on this particular treatment. We also worry about steroid therapy. Would that affect it? Because steroids are used for the adverse event rate. I have no data on steroids, but hormones, again, anecdotal data, that's all I have for you, appears not to in prostate cancer. But very important question, because patients want to stay on these treatments while they try the new experiments.
Yeah.
Yeah.
The other one is, of course, the patient nightmare is the bony metastasis, because that is very painful.
Yes.
If you have fibrosis afterwards, that could be that the pain continues.
Yes.
So what you have found about the pain?
The good news for us was that when there was fibrosis, the mass had still shrunken in every case, which was good news. None of them get bigger. So there's no pseudo-progression of getting bigger. It's really, I coined another term, but I won't go into that. But instead of pseudo-progression, because it's not progressing, it's just a pseudo-stabilization. That's a weird name. Please don't quote that. But I hear what you're saying, though. That's very interesting. Thank you again.
That's all we have for questions. I'd like to call up Jamila to present David with the award. Sorry.